This will be our first dive into the cardiovascular system. We're going to begin talking about expected and unexpected findings for various disease processes. We'll look at how to assess clients, ensuring that we're using proper assessment techniques, how to look at and interpret various vital signs and what they mean for the cardiovascular system. We'll be talking about taking a health history from a client that is going to be specific to the cardiovascular system, so a focused assessment. And then by the end of all of these videos, so all of my cardiovascular content, I want to be able to have a entry-level nurse be familiar with what's normal, what's concerning, and the best ways that I can handle or care for clients with these various comorbidities. So the first thing that I want us to remember is to think about our anatomy and physiology classes. We're not going to talk or discuss blood flow through the heart, as I think that you are probably aware of what that means. Instead, what I want us to focus on is, if I have various comorbidities, what's that going to look like for our clients? So using this model here, I'm going to start on the left side, in the left ventricle. And I have the aortic valve. That would be highlighted in purple there, pretty close to the mitral valve. So if I have issues where I have structural changes, if I have stenosis, if I have incompetent valves, what's going to happen is when that left ventricle goes to push this blood out of your heart, out of the left ventricle, and into systemic circulation, you're going to have changes in how much cardiac output this client is able to maintain. And because I'm unable to maintain that normal cardiac output, that blood is then going to back up into my left atrium. And when it's filled there, it's going to back out to my lungs. So one of the things that we're going to talk about with heart failure. So if I have issues and if I have an ineffective pump through any various cardiomyopathies, you're going to experience the same signs and symptoms that you would for anything that was on the left side. I'm talking specifically about the left side because that is the area of the heart where we're going to find clients have the most issues, because the left side does most of the pumping against a higher pressure than the right side would have to go against. So as we think about this, and you think about those signs and symptoms, it's very hard for an educator to ask you information that is vague, because the signs and symptoms of all of these cardiovascular diseases is pretty much the same. And we talk about the perfusion words, where you're restless, irritated, agitated, you're short of breath, you need to sit upright to take good breaths in. You have blood pressures that are either unusually high or unusually low. So it's a kind of mix of everything that we've seen across these comorbidities. So what we have to do is we have to give you folks enough information to make an educated decision. And then we will outline, some of those assessments and interventions that are specific to whichever comorbidity that we're looking at. So just basic review, right? I'm not going to put, the heart consists of 4 layers or and name them on the exam. But I want you to be familiar with them, because when we talk about these layers, the pericarditis, the myocarditis, and endocarditis specifically, we will be looking at some of the inflammatory disease processes. So again, just to remember, the pericardium is the sac surrounding the heart, and it does contain a small amount of lubricating fluid, and it does that to keep the rest of your heart safe from the friction that we would normally see if I did not have the heart in this sac, because of the constant inflation and deflation of the lungs. So it's a very, very, very small amount of fluid. Later on, when we talk about pericarditis, or these inflammatory disease processes, one of the things we're going to have to observe for is something called cardiac tamponade. And that will be all about that 15 to 50 milliliters. Instead of saying 15 to 50, you start accumulating fluid in that sac, which is going to put extra pressure around your heart. The epicardium is, of course, just the outer surface of the heart. The myocardium is the piece that does the majority of the work. It's the musculature, contractile portion of the heart. Your heart wants to beat in a rhythmic pattern. It wants to beat love-dove. The endocardium, then, is the inner layer of the heart, and again, that's for protection, so that we can have normal blood flow in and out of those ventricles and atriums. So, aside from 4 chambers, we also have 4 valves. I always like to draw it, and you're going to have to excuse my drawing. Not the best drawer on a computer screen. So I always do my hearts kind of like this. So I have up here, I have the atrias and the ventricles. And we know that blood returns via the superior and inferior vena cava and into the right atrium. Well, then the next thing it needs to go through is this tricuspid valve. So we have a tricuspid valve between, and that's where we get the atrioventricular. So it's between the atriums and the ventricles. So, and of course you can have various issues with the tricuspid valve. They're not really as prevalent as the mitral and the aortic, but you do see some right-sided disease processes, and mostly what you're probably going to see is something that's going to affect the pulmonic valve. So the tricuspid valve is on the right side between the atrium and the ventricle. The pulmonic valve is what takes that deoxygenated blood into the pulmonary vasculature. And it is under some pressure, but again, it's not nearly as much pressure as the 120/80 that the aortic valve deals with. But it's more like, 30, 45/15-ish numbers. So less pressure to go against, but you do come up with something called cor pulmonale. And hopefully, if you've had respiratory already, that you understand that that is right-sided heart issues related to changes to the respiratory system. It's still pulmonary hypertension, so it's still related to the heart. It's just secondary to a different disease process. So we're going to go back to the left side now, and just like with the tricuspid valve, we have the mitral valve. So you may have heard try before you buy to help you remember the left or right. So the mitral valve separates the left atrium and the left ventricle, and we know because of where it's located that it's an AV valve. And then in the left ventricle we have the aortic valve. And this is the one where we can have some really serious complications, or more serious than the other ones. But again, you notice it's on the left side, and it is the one that handles the pressure of something called SVR. We'll look at SVR later. It's not something that's testable, it's just a concept. So SVR is what's over here called systemic vascular resistance. When we talk about resistance, we're also going to call SVR something else. And again, I know we have so many different names for all the stuff that basically mean the same. But basically what we're talking about with SVR is afterload. So afterload is over here, and your preload is volume that's coming back to the right side of the heart. So we'll talk about those terms later on as well. course, as a good nurse, I know that I need to put my stethoscope on people and listen to heart sounds. And we're specifically going to do that through the All Physicians Take Money. So, what we're going to concern ourselves with is taking our stethoscope. If you have a cool high-speed Littman's or something, you've only got one side, so you don't really have to worry about it as much. You just use that because it's a cardiology stethoscope. But most of us have dual-sided, so you have the diaphragm and you have the bell. For our heart sounds, we want to make sure that we are going to listen with the bell of our stethoscope because they're more high-pitched. And you would only listen in these 4 spots if we suspect that the client may have some sort of valvular issue. Otherwise, we would just do our normal cardiovascular assessment, listening to the apical heart rate. Again, this is just if we notice something is different or we're trying to rule out something. So if you suspect that it is in the aorta, you're going to listen at the right sternal border, right? So right there. Second intercostal space, that's your ALL, or your aortic valve. Right across the street is the pulmonic valve. So I have now left and right-sided ventricle valves, so our semilunar valves accounted for. And notice that because of the anatomy and physiology of how the heart basically turns up on itself, that the aorta and the pulmonic valve are actually higher anatomically than what we drew with our little box. So right below the pulmonic valve is your tricuspid valve, and normally we say it's the 4th or 5th intercostal space, left sternal border, and that just is going to depend on your client, how big or how small they are, the body surface area, all those other extraneous factors that you just have to kind of figure out depending on each client. Then we're going to go to the 5th or 6th intercostal space, and this is what you guys know as the midclavicular line. So we're going to have our stethoscope there, and it's probably the area that you're most familiar with because it's really close to your Erb's point and your apical heart rate. So just nice way to remember it. And really the only reason that this is here is that I tend to see a lot of hot spots. And a lot of the practice in CLEX RN questions and CLEX PN questions, whatever it may be. So you do have all those next-gen questions, so you should know where to auscultate heart sounds. Okay. We need to be able to recognize, just like you would for a client that had a AV fistula, a hemodialysis client, what a bruit and a thrill are. So bruits are just extra noises. It's essentially like a murmur. A murmur is going to be a common expected finding when we talk about like congenital heart disease or heart failure. You can expect maybe to hear a murmur. Some of your valvular heart diseases as well. So what it probably is telling me is that I have a structural change in my arterial system. And you look down here, you can see that it has a carotid stenosis or other artery stenosis. So you have that narrowing, or the client may have, if it's further down in the abdomen, something called an abdominal aortic aneurysm. It's a AAA. It's a vascular heart disease. We'll talk about it when we talk about vasculature. But just right now, know the most important thing that you can do for a AAA is to monitor it, to make sure it's not getting bigger, and to tell the client to take their blood pressure medication. And then you're going to have thrills. So thrills are just the vibration that indicate a severe. So now you see the only real difference here is it's severe form of turbulent blood flow. And again, it's usually because of a valve or because of an arterial obstruction. We put a link to a YouTube video here. It's a good place to go listen to heart sounds. I won't put heart sounds on my exam, but for you really high-speed nurses who are going to go out there into the ICU or the EDs, it's a nice resource so that you know what you're listening to. one of the biggest things I get from students in clinicals when they come up to me is like, I don't know what I'm listening to. And you have resources for that. My answer to the students is always, I want you to put what you think it is because it's your assessment. And I got a lot of students that like to use diminished lung sounds. So usually that doesn't mean a whole lot to us. We're not worried about diminished lung sounds unless we throw some of those other advantageous noises behind it. Okay, just talk briefly about the coronary arteries. So we know that we have, or the heart needs to have its own blood supply. It receives that blood supply from the coronary arteries. So basically, right off of the aorta, there is the coronary arteries. They branch off from that. So as soon as your left ventricle contracts, the first place that oxygenated blood is going to get to is to your heart. So you have your heart and then you have your brain. So we do see that we have the right and left coronary arteries and the left anterior descending and circumflex arteries. And again, that's not something I'm ever going to ask about. It's a very A&P-ish, right? We only need to know that because we'll talk about the LAD here and how it's going to be affected when you have MIs. It's on the next slide. You see how it branches off to the left circumflex. The posterior descending is over here. You have your right coronary artery over here. So you have lots of opportunities if you have a history of atherosclerosis or arteriosclerosis to develop problems long-term down the road. We know that because of those disease processes, either the plaque or the hardening, that your heart compensates for that. That's why we may not see signs and symptoms for years at a time. Because our body is so good, it masks the signs and symptoms of heart disease. So we don't think anything of it if I get short of breath climbing 3 flights of stairs. Oh, I just need to work out more, whatever it may be. But it could be something hinting at that maybe as you age, your cardiac system is getting worse. If you're somebody that doesn't go to the doctor regularly and you don't know that you have hypertension, you don't know you have the hardening of the arteries and the plaque accumulation, it can lead to some serious problems. And I always equate this to, like, you hear about the young, fit, usually men who are out on a morning run and who collapse of an MI. Their body has been compensating for those problems for so long that by the time something does happen, you're probably 90% occluded, and unless we catch it in an emergency room or on the floor or something, it's a good way to have an MI and not make it. So here's exactly what we were talking about. This does a really good job. Up here we see that you have this 95% blockage. And over here we see a better picture of it. But it also does a really good job of showing you all of this collateral circulation that your heart is trying to use to compensate for this area of occlusion to get blood flow down to the left anterior descending. And yes, this is the one that they call the widowmaker. It's not going to really change your care. Just expect that, they're going to come in and we're going to take them through the whole either STEMI or non-STEMI process. It's the acute coronary syndrome process. And what it could look like, if you look over here on your right, I have the heartbeat from a telemetry strip or a 12 lead, doesn't really matter. So we see P, we see that this client does have a Q, they have the R, and here is the S. So most of us have probably heard the term STEMI or NSTEMI or non-STEMI. The N and the non are used interchangeably sometimes. What I should see with this S wave is that it should come back down to this isometric line, so this flat line here. So it should come down to or past, and then it should come back up to your T wave, right? This one has the ST segment, so this little point between the S and the T wave. It is elevated away from that baseline, so that's what you would call a stemming. And that's going to be really, really emergent for that client. And when we walk through CAD and ACS, we'll talk about the difference between stemming and end-stemming. We know that our hearts, in order to have the mechanical pumping action, we need to have electricity. So we know that the heart has specialized cells that create and transport those electrical signals. And we do that because we want our atria contracting at the same time and relaxing at the same time, and our ventricles contracting and relaxing at the same time. So the SA node is going to be the pacemaker of your heart. So you see it's up here on the right atrium. So it's important that all of the cells in your heart have that ability to carry that signal. So the SA node has an inherent rate of 60 to 100 beats per minute. That's one of the ways that we maintain cardiac output, which we'll talk about later as well. If something were to happen with your SA node, the AV node can take over. What we need to recognize with the AV node is that its inherent rate is only 40 to 60. So that may not be enough to maintain cardiac output. So the way that it functions, it should be that the signal originates in the SA node. That's what would make those rhythms sino or sinus. So it's a sinoatrial node, so a sinus rhythm. It should initiate that signal, and what should happen then is once it leaves there, we get down to that bundle of His breaking off into your bundle branches. So over here you see with their arrows. And then you have the AV node that's sitting right there. So really close together. These are basically your body's way of slowing that signal down to ensure that you have adequate cardiac output. So when my atriums are contract, my ventricles dilate and fill. And that's your P, PRI, QRS. And then your ventricles will relax again, and again your atrias will contract. And that's your T. So with the ventricles relaxing, that makes your T. So each cell in our body, in our heart, has these properties. So these four things that make it do what it's supposed to do. They have automaticity, excitability, conductivity, and contractility. So our cells want to be able to contract in an independent manner. So we have that signal that travels through the heart that tells each cell that it should be doing something. This excitability means that you have the ability to be electrically stimulated because of the ion shift related to mostly calcium, potassium, and magnesium. And those are going to be our big three electrolytes that we talk about. Obviously, the main one for us is potassium, but calcium does play a really crucial role, as well as magnesium, in making sure that your heart doesn't become agitated. Conductivity, again, because those impulses travel to other cells. They all need to do that to produce this contractility. So how well the cell contracts. And that contractility piece is going to be related mostly to cardiac output. We'll look at the ejection fraction, we'll look at the cardiac output, we'll look at mean arterial pressures. I need contractility for all of that to mean anything to your body. So that's basic anatomy and physiology for us. Let's now get into what I would call the minutia, the stuff that it's really, really good background information, but I don't think anybody on an exam is going to say, the nurse is caring for client X, and this is this, and that is that. What is the client's cardiac output? That's not something that we can do as basic nurses. That's not something, unless they're in the ICU, that I'm even going to have all that information for. But when I do talk about cardiac output, you do things every day at the hospital to change cardiac output. So cardiac output equals heart rate times stroke volume. You all know what heart rate is. So the higher it goes, the more you can pump out up to a certain point. Because then if you have those really, really fast tachyarrhythmias, you're not going to have any time for the ventricles to fill with blood. And that's why we have normal sinus rhythm, sinus brady, sinus tach. We can still expect some sort of cardiac output out of those. So you see, just like we said with each part of the heart, I have the ability to maintain cardiac output related to the pump itself or to the volume. We are going to say most everything in cardiovascular from a disease process and from a normal process is going to relate to either a pump issue or a volume issue, and sometimes they decide to get together and make it a really, really bad issue. So we've said cardiac output equals heart rate times stroke volume. See that here. A normal cardiac output for us is going to be 4 to 8 liters per minute. So liters, not milliliters. So it's really 4,000 to 8,000 milliliters a minute. So I want you to think about that. You grab, 8 large 1,000 milliliter saline bags and you try to squeeze out all of that volume in 1 minute. I don't know about you, but I know that that's pretty hard to do. So we're going to look at those things to make sure that our client is perfusing. Cardiac output is going to be influenced by preload and afterload. So I want you to notice that those words basically are what we talked about earlier, that everything in cardiac is either a pump issue or a volume issue. So preload is exactly that. It's the volume of blood returning to the right atrium. Afterload, because it is a resistance, it's going to have an effect on your pump. Right? So now I see I have issues with volume or I have issues with my pump or the resistance. And again, we give fluids and we give diuretics. So I can increase or decrease preload and afterload. I can get decreased afterload by giving blood pressure medications. So we are going to look at just basic nursing care, nursing interventions that we would do for a client who has a cardiovascular issue. The ins and outs of it are preload, afterload, cardiac output. And then I'll show you how we'll take this information and we'll turn it into test questions. So we define preload and afterload. Again, that's not something that I'm going to ask you to do on the test. It's good background information for you to understand what's going on with the cardiovascular system. So here we see that I have certain things that are going to contribute to a decrease in preload or a decrease in afterload. And I just point out the stuff in red, not because it's on the test. Everybody wants to think that, right? But because it's important. So with a decrease in preload, you have a decreased volume. So if I have continuous IV fluids, and then we're going to talk about this concept later, the central venous pressure. It's something that you'll probably get in the ICU. But it's a number that's sort of going to tell us either wet or dry. So really low numbers are going to be dry, really high numbers are going to be wet. So if I have a client who came in and they're having a burn issue, because burns can relate to the cardiovascular system if it's an electrical burn or something, and I'm giving you a really large amount of fluid, and you don't make urine, then that's a problem. So you see what we did is we have changed the concept of CVP just to reflect what it would be on I's and O's. So if I had you on a really high rate of fluids and you weren't making urine, you're probably fluid volume deficit. Now that's an NCLEX style question. I don't have to ask you about a CVP, but I can ask you about a client whose blood pressure is 60/40, and then you should be able to determine good fundamental basic nursing care for that client. All right, so here we talk about what we're going to assess for. So changes in LOC. And what I want you to do is notice that for both decreased preload and increased preload, a lot of these assessments are going to be the same, just like we said earlier. So then we have a murmur, just because you may have some blood flowing in there. It's rather turbulent because your blood is thick or viscous or whatever it may be. But more importantly, you come with a decreased urine output. Well, what's the treatment for decreased preload? You guys know that normally we're going to give them IV fluids. But probably more importantly, we want to treat the underlying cause. If it's because they have a GI bleed, we need to fix the GI bleed. If it's because there are geriatric clients who don't drink because they feel like they can't get up and make it safely to the restroom, and then they end up with an infection, they end up with dehydration, or more severe clients have it, or are going into either cardiogenic or hypovolemic shock, and those are the only two that I will cover for the cardiovascular system. So you are fluid volume deficit. Now increased preload, you are fluid volume overload. So now you say I had a low CVP, and instead of saying I'm wet, we just say I have a high CVP. Or CVP, I think later on our normal numbers, you'll see it's 2 and 8, 2 to 8. Sometimes you see in the books 2 to 6. But it's just another measurement for nurses, again, ICU nurses mostly, to help determine whether or not therapy has been effective. So again, we see the same concept. If I'm giving you a high volume of fluid, but your CVP is like 12, I probably need to stop the fluids, because now it's telling me that you're vascularly wet. You still assess for the same changes, but now we're going to make them about shortness of breath, edema, fluid volume overload. So where is that fluid going to go back up to? It's going to back up to the heart, or to the lungs, and then to the body. So the lungs would manifest as crackles. Treatments, pretty much we're going to use things to decrease preload, decrease afterload. And there I see my vasodilators, and I see diuretics. Diuretics will actually decrease preload and afterload, but it's what I want you to do is to be able to figure out if you have fluid volume overload, you're probably going to get diuretics. If you have issues with your blood pressure is 200/100, you know you're going to probably give hydralazine or metoprolol or things that promote vasodilation. And you're still going to treat the underlying cause. That's hand in hand with it's a pump issue or a volume issue. Treat the underlying cause is always a good answer for cardiovascular. Okay, we'll talk about afterload now. And again, we said afterload is just our resistance, right? So decreased afterload, decreased resistance, that's going to change your blood pressure. That's going to change your cardiac output. Heart rate times stroke volume. So you can have a low blood pressure and a high heart rate initially. Eventually, those compensatory mechanisms will fail, and you will end up in shock. Again, you can see that as far as assessments and treatments, it's pretty much the same. Changes in LOC, are they making urine? With an increased resistance, and now I have a really high blood pressure and a really high heart rate, and again, initially that may be okay, but in the long term, what's going to happen is your heart's going to wear out because of that increased resistance, and you're going to have these structural changes. Those are your cardiomyopathies that we'll talk about with heart failure. Where heart failure isn't actually a disease, it's a classification of other diseases. So your assessments: shortness of breath, edema, and crackles. Treatments: vasodilators, diuretics, treat the underlying cause. So I know that these terms are really, really new, but as long as you recognize that really all we're talking about are how well your client's vital signs are, will help you make preload and afterload make sense. Okay, so that's our knowledge check. Did you notice those assessments are the same? Everything in cardiac, generally speaking, for new graduate nurses, can relate back to a pump or a volume issue. Your job as the nurse is to ensure that your client is perfusing. So we're going to talk about your vital signs, your focused assessments, your urine output. And we're going to start looking at how all these disease processes are really intricately connected, especially things like kidney disease, diabetes, heart failure, hypertension, COPD. You would be surprised that most of our clients that come in probably have some sort of combination of those disease processes. So, we know what cardiac output looks like. Now I need to make educated decisions about what is going on with my client who has either decreased cardiac output or an increased cardiac output. So we'll talk about these terms. An ejection fraction is basically another way of saying your stroke volume. But instead of saying, okay, my stroke volume is 100 milliliters, I'm saying my stroke volume is 60%, 70%, 80%, whatever it may be. All you're really doing is taking this number, and so now my stroke volume was 100, and my volume of blood left in the chamber, and then you just divide them, and that will give you your actual ejection fraction percent. That's not something that we can do. We're going to have them be evaluated with an echocardiogram. So it's either going to be a transesophageal echocardiogram or a transthoracic echocardiogram. And mostly what you'll see that is if you have a client who has an acute exacerbation of heart failure or a new diagnosis of heart failure, we have them get the TE or TTE so that we can determine cardiac output so that we can start thinking about their treatment plan. And then we'll look at what some of that looks like when we talk about heart failure by itself. Mean arterial pressure, you guys get that every single time you take a blood pressure. The robo nurses do a really good job of giving me my mean arterial pressure. For us, we want to ensure that our maps are greater than 60 and less than 120 because numbers below 60 or greater than 120 indicate you have poor perfusion. So that's why hypertensive crisis is such a big deal, and that's why hypotension is such a big deal. So there's a couple formulas that you can use. I don't care which one you use, whichever one you're comfortable with. This diastolic times 2 plus systolic divided by 3, that's just too much for me. I can't, I want you guys to be able to do stuff quickly. So I much prefer this one because then I know if I just look at that number and it is between my 60 and 120, that my client's perfusing. I don't have to do the calculation. And I don't believe any good educator is going to ask you guys to figure out a map. But what we want you to do is I'm going to give you a blood pressure, and that's the examples that I'm going to show you. I'm going to give you a blood pressure and ask you, do you know which client you should see first? Do you know what the treatment plan is, what the plan of care is for these clients that have these blood pressures? So we know then that MAP is influenced by cardiac output and SVR, because that's going to be our calculation for blood pressure. Blood pressure equals cardiac output times systemic vascular resistance. We talked about if it drops below 60, you have ischemia or infarction. If it drops significantly, blood is not going to be able to maintain perfusion to your cerebral tissue. You will have changes in LOC and probably some sort of brain anoxia. For us, for a general nurse, MAP is your best indicator of perfusion. Obviously, if you're in the ICU, you have direct access to probably an art line, pulmonary artery wedge pressure, central venous pressure, Swan-Ganz, so all the cool stuff. So again, here is just the way of calculating them. So here are your normal parameters, right? And then here are the formulas that you can use. So here's our example. I don't even need to do anything with this, because when I look at that diastolic, I see that that diastolic is really low, and it's right in that sweet spot. So even if I add a little more because of my formula, I know that that is going to be that that client is perfusing. The next two really get students, because when you look at one versus the other, you're like, oh, well, clearly, you know, that third one is much worse than that second one. So let's look at it. So our first one is the client perfusing. Yes, their MAP is about 93. What do we think it is? 85 over 55? Are they perfusing? Yes, because that number is 65. Even though the diastolic seems low, I know because it's really close that I'm going to add something back into it, and I'm pretty sure that I'm going to add at least 5. In this particular case, it came out to be closer to 10. So even though this number, I'm going to tell you guys, hey, anything less than 90 could be potentially indicative of shock. That's absolutely true, and you should pay special attention to that client, especially if they're trending down. But for now, this client is perfusing versus our next client, whose systolic looks really good. Okay, 90. Shockley said anything 90 or above, you're okay. But when I look at this number, that's when I know that I need to really look at the map of the client. So if I put these 3 clients on a test question and said, hey, the nurse is caring for 4 clients. Here are their blood pressures. Obviously, I only have 3 up here, but you get the point. Which client should the nurse see first? So now I have taken this really maybe kind of confusing to some students, but it's the concept of mean arterial pressure. And I did not ask you to give me a number. I just said, hey, who do you see first? If you are somebody that's only looking here and only remembering that Shockley said in class 90, you're going to get that wrong, because you're going to try to pick this guy, but he's perfusing, versus this guy who is not perfusing. So while a low heart rate is assessed and evaluated, it is not enough to tell you about perfusion. Notice that most of our medications have parameters for the blood pressure, and only a few have parameters for heart rate. You need to look at your client's map before making a decision about who you see first or which is most critical. Because your job is to ensure that your client maintains perfusion. Yes, you know my 3 favorite words are perfusion, 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 followed closely by it depends. So every single test question you need to ask yourself, is my client perfusing? So I could theoretically put this telemetry monitor on a test. Gives you the heart rate, UCP, UCQRS, UCT. What are you going to do for this client? Clearly, a heart rate of 38 is not going to be enough to maintain perfusion. We'll just remind you, heart rate times stroke volume equals cardiac output. So I'm going to make it 40 because 40 is simpler for math. So my heart rate is 40. If I assume that I have even, remotely a good heart rate, or stroke volume, I'm going to take, say, a stroke volume for a normal number, we'll say 60. And we know that then your cardiac output is only 2.4 liters a minute. And we said normal cardiac output should be 4 to 8. So 40 beats per minute times 60 milliliters for stroke volume, not enough to maintain cardiac perfusion. So what's going to happen is you're going to have a decrease in cardiac output, which leads to a decrease of perfusion in the body. And then we're going to go through our process of airway breathing circulation. All right? So because of fluid backing up, you're going to have crackles. You can be short of breath. Your skin will be cold and clammy. You will have decreased urine output and decreased peripheral pulses. All right? You're going to have an LOC change because once blood leaves your heart, about 20% of it is used by the brain. So if you're not maintaining a normal cardiac output, that's why we have agitation, confusion, restlessness, all those perfusion words now. So that's what it would look like from a big picture standpoint. Your heart needs its own supply of oxygen. The more work that it does, the more oxygen it needs. So let's look at the factors that increase myocardial oxygen demand. All right, we're going to say probably those three words together a lot because you can have something called demand ischemia or you can have a true MI. So demand ischemia just means that you have a bad pump. Usually if you're talking about heart failure or an acute exacerbation of heart failure or acute on chronic exacerbation of heart failure, however your doctors put it in the MAR, in the notes, you know they're probably going to be tachycardia. They're going to have an increased force of contraction because it's trying to push out more blood due to either too much or too little volume. So now the volume affects your pump. And then as a compensatory mechanism, your kidneys are going to send out renin, and that's going to cause vasoconstriction. Well, now that compensatory mechanism that we would normally use to help us is going to hinder us because I've got a bad pump, and now I've got increased resistance. So remember, we want to figure out what's the cause of this. And can I treat the pump? Should I treat the volume? What do I need to do to make this client hemodynamically stable from a cardiovascular standpoint? All right, and that leads us to our last couple concepts here. You guys are all familiar with orthostatic blood pressure readings. So we're looking for changes in the blood pressure. Usually it's a drop by at least 20 millimeters of mercury and an increase in the heart rate while sitting, standing, and supine. So I'm looking for changes in how well your heart maintains adequate perfusion. This is important because if I have somebody come in and they have a new diagnosis of heart failure or a new diagnosis of hypertension or something along those lines, and I'm giving them medications that are going to help change that cardiac output, it could potentially lead to some changes into your orthostatic blood pressures. So make sure that your clients understand, especially if they're taking a blood pressure medication. There's a million reasons I could take a blood pressure medication other than blood pressure. If they're taking that initial dose, that, hey, you need to call for help when getting out of bed, especially on our geriatric clients, or they're going to be at increased risk for falls. Pulse pressure is simply going to be the difference between systolic and diastolic. It's not something you're going to ever really use. We say that this pulse pressure is an indirect measurement of stroke volume. However, normal pulse pressure is like 40-ish, 40 millimeters of mercury. So that's not really true. I would expect that you would have a better stroke /volume than 40 milliliters. But what I want us to recognize with these pulse pressures, say I have a blood pressure of 85/65, and it has been trending where both the systolic and diastolic are coming together, then you know that you have this thing called a narrow pulse pressure. And usually that's associated with the client probably experiencing some sort of issue with cardiac output, which could mean shock, aortic stenosis, dysrhythmias, congenital heart disease, that's the patent ductus arteriosus. So we've covered the narrow pulse pressure. What about a widened pulse pressure? Now, notice the difference. Narrowed is all capital letters, widened is small. It's still important, but for widened pulse pressures, generally I think more of like a neuro or distributive type of shock. And this is your client is like, oh no, my systolic is 180 and my diastolic is 45. And it's trending where that pulse pressure is moving away from itself. So again, it's just a tool. It's nothing that is going to greatly, profoundly change your nursing care, but it helps you keep track of what is going on for the client cardiovascularly. All right, so those are basically our key terms. Good information there. I know it's different, right? Most of this cardiac, the way my college does it, is different because we don't give it to you over your entire nursing education. We give you hypertension, and then at the end we give you, hey, here's all the acute situations with the cardiovascular system. But put it in terms that you understand. Make it make sense to you. Just because your instructor or whoever you watch to help you study, just because they know something a certain way, I need you to understand it your way so that you can pick the correct answers on the exam and on the NCLEX RN. So our next piece of this is actually looking at a client and doing this focused assessment and working through the various problems that we run into. So let's look at it. Just a couple little side notes. One of the biggest things that I always see in clinical is that students will try to use whatever blood pressure cuff is in the room regardless of whether it is appropriate or not. So the wrong size of the blood pressure is the most common reason for mismanagement of blood pressure. I can't tell you how exhausting and infuriating it is for me to see a client who has a blood pressure charted, and in Epic it's red. If you're not familiar with Epic, it's our charting system that we use in the St. Louis area. And if you have an abnormal value, it's red. And then what don't I see? I don't see that you've come through and you've reassessed the blood pressure either in a different location or manually. We get so ingrained in just doing the task that we forget that there's a reason that I need to have an accurate blood pressure, heart rate, because we're going to be making a lot of our decisions based upon that information. Okay? So make sure that you are using the right size cuff. My next one is location. we should all recognize that our cuffs have a line on it to tell you to line up the artery here. And we all know that the artery that we mostly use is going to be the brachial artery. It's your upper arm. It's on the inside. If somebody could please explain to me why I walk into a room and I have the line in a completely wrong location, why that we just choose that we're going to randomly change the directions on how to properly use a blood pressure cuff. And it's silly stuff. And I know it's because you guys get so swamped with taking care of so many clients, but you still need to make sure that you're doing the right thing. Just because something is in the room doesn't mean it's the right thing. All right, we've talked about changes to cardiac output. Cardiac output, again, is heart rate times stroke volume. So if you have changes in your heart rate, it's going to mean changes to your cardiac output. This is one of the reasons that we know that we do an apical pulse for our beta blockers, our non-selectives. So as the heart rate increases, it's a good compensatory mechanism. And I guess the key for us is up to a point. Right? My heart rate is 120. We're not like running down the hall looking at this client. Their heart rate's 120. Oh my gosh. But if it starts to get to 150s, 160s, and we see dysrhythmias, PACs, PVCs, whatever it may be, we know that those compensatory mechanisms are probably failing. Because the next thing that you're probably going to see is changes in LOC and drop in SpO2s. Because changes in cardiac output could potentially mean that they are experiencing shock. So as a good nurse, what I recognize is that tachycardia is the earliest indicator for all clients, that includes our pediatric clients, that there is a pump problem. Right? So it doesn't matter if it's CAD, ACS, heart failure, structural, inflammatory, congenital. The earliest indicator that your heart is doing more work is an elevated heart rate. So when we're looking at these vital signs, we observe for compensatory mechanisms, we track, we trend, heart rate, blood pressure, respiratory rate, SpO2, temperature, all those great things. We do assessments. We feel for pulses. That pulse strength decrease in, should be a line there. Pulse strength is a decrease in cardiac output. Output will be reflected in a decreased or weak peripheral pulse. Right? Weak, I can live with. Weak and thready is deadly. We'll look at a couple of the disease processes when we get into vasculature that would cause weak and thready. This should be vascular and shock. So we can look at a pulse deficit, which is the difference between the apical and radial pulse. Usually, this can indicate a dysrhythmia. So I want you to think about your clients who were admitted and they have either a new diagnosis or a recurrent diagnosis of atrial fibrillation. When you look at the monitor, if they're on continuous pulse oximetry, you get a continuous pulse, and you see that heart rate jumping up and down, and it just does not stay consistent, it's probably because they're in AFib. And because of the irregularity with AFib, you have changes in that heart rate all the time. So for that client, it may be impossible to actually palpate for a pulse deficit. So for us as a nurse, what I would say is that I'm going to use a lot of objective information, right? That's my most important tool to help provide adequate care. And I'll give you an example of the difference between my objective assessment and my subjective information. my client is satting 80% and it has a good pleth. All right, so I got my waves in the ocean for my SpO2. Do I trust this? Yes, I do. It's objective information. My client talked to me and told me that where she was from this morning, and now she thinks that she is in Honolulu. Again, objective information. I want to see the client, if I know I have objective information, who is appropriate for that prioritization. So people who are having changes in LOC, people who are changes in their SpO2, who have anything new. Have you ever been reviewing a test or taking a test and the instructor is nice enough in the distractors to tell you, oh, it's a new onset of X disease? That's acute. They're trying to tell you, look at me, look at me. It's new. It needs to be addressed. A client now tells me I'm short of breath, but they're satting 95%. That is subjective to them. They feel like they are short of breath. Am I still going to do something? Absolutely. I'm going to raise the head of the bed because there's no need to administer or titrate their oxygen, because what we're trying to do is to open up their airway, to open up their lungs so that they feel like they are breathing better. So that's the big difference when we're thinking about subjective and objective information. And, you know, the road kind of goes both ways. You just need to be able to look at it and say, okay, which of these two clients should I see first? Which is the most critical? Whatever it may be. Either way, I am going to develop a plan of care. The client will be able to maintain normal SpO2s. You know, we don't do nursing diagnosis anymore, so there's no as manifested by and related to. But if you still think like that, that's a good thing, right? I have now developed specific measurable objectives for this client. So now that I've got those goals in mind, I need to continually evaluate that information. I don't know why I said evaluate like that, but we'll take it. So in obtaining this information, I want to do my focused assessments. You know, if you know that the issue is cardiovascular, make sure you're doing all parts of the cardiovascular assessment. I'm just going to use the example of doing simulation. I know most students probably don't like it. They feel uncomfortable because of the mannequin or because of the instructor watching them continuously, whatever it may be. But one thing that I notice is, like, you will get, not you, but generally speaking, students will get super hyper fixated on you know, an SpO2 that's 90. And just because the order says titrate SpO2 to maintain SATs greater than 92. And we run in circles. Even though the client's talking to them, they're not complaining of any pain. Oh no, they're satting 90%. And then we forget that, oh, they also have a history of COPD. Am I really worried that their SpO2 is off by 2%? No. Could I potentially titrate oxygen? Sure. But it's probably not an issue with their oxygen level. So what we do, I'll give away the secret tips here, is we give you a client with AFib, and then you don't do an adequate assessment of their pulses, specifically their pedal pulse. And guess what they have? That's right, they have an absent pedal pulse. And you have completely ignored it for the 3 hours that we were in the sim room. And that is why you can't get their SpO2s greater than 90. In the real world, could you do it? Probably. Slap on a non-rebreather, get their sats up, or whatever it may be, but you're also going to have backup, right? Oh, I've got other nurses here to figure out what's going on. Sometimes you don't get that in the real world, so you've got to have a really good system of performing focus assessments. So for us, airway, breathing, and then that last piece, we forgot this circulation piece for the cardiovascular assessment, and that's why we miss it. We get distracted, and that's what nursing school is good at. We're good at distracting you away from where the real problem is. So once you've completed your focused assessments, you can move on to your secondary assessments. These are your history and physical, your complete head to toes, finishing up bowel sounds, finishing up your neuro checks, your lung sounds, inspecting the skin, inspecting for any disabilities, exposures, if they've been near drowning, or if they've been in a fire, whatever it may be. This is where we obtain a full set of vital signs, and this is where we do all of our Maslow's. Right? So Maslow's is part of this secondary assessment. Airway, breathing, circulation is always first. Change in LOC, acute before chronic, least invasive to most invasive, and then Maslow's. All right? So you see down here, you've got this little note from emergency trauma assessment. Still starts with airway, breathing, circulation. I'm going to change emergency. So change emergency to your acute. If I can get the pen to work. And bad spell. So the acute assessment. And you're still walking through each part of this side of our big arrow here. So I want to go through my client's health history. So I want to talk to them about, hey, what symptoms are you experiencing? Do you have any allergies? What are your home medications? What is your past medical history? What's your last oral intake? And what were the events leading to the admission? Now this is a good tool. It's obviously not in order, right? Because we can ask these in a different order that would make much more sense. But it's whatever you're comfortable with. The good part is that all of this is in our individual charting systems. So if it's Epic, it's in your navigator, your admission navigator, whatever it may be for wherever you work. So we're going through part of our focus assessment. Again, we're looking at our history of the present illness. We're going to get further into that, right? So describe the complaint. Okay? If they state that they have pain, make sure that you're asking them OPQRST. Again, this is one of my pet peeves. I go in there, I'm reviewing charting for our students, and they've documented the pain was 10 out of 10 at 7 a.m., and there's not a single other follow-up assessment anywhere to be found. Right? Pain is your fifth vital sign. You have to address each part of OPQRST. Right? We can look for fatigue, especially if they're up in ambulatory doing something. Look for your edema. Ask them about any fainting spells, right? Feeling like they're going to faint. Any difficulty breathing at night. Postural, nocturnal dyspnea, right? They feel like they're having any palpitations, the heart is beating faster, to feel it's skipping a beat. If I have a productive cough, and is there hemoptysis with it? Do I have signs and symptoms of claudication? We'll talk about claudication later, but it's basically leg pain when you walk because you have a history of PAD. And then I's and O's. We're going to talk about continuous I's and O's and daily weights. And I'm just going to remind everybody that this is a cardiac test. I cannot wait 24 hours or how many ever long hours it is to get that morning weight to determine whether or not my therapy has been effective. So I'll give you the example that if I give 80 milligrams of furosemide IV push to a client with acute decompensated heart failure, and I give it at 9 a.m. on the 1st of the month, do you really want to wait until 6 a.m. on the 2nd to determine whether or not that Lasix, that furosemide, was effective? So I know we beat this daily weight thing into you guys. I just want you to trust me with the cardiovascular system. You are not waiting 12, 16, 18 hours, and sometimes they don't even get the daily weight at that, to listen to lung sounds. I gave the furosemide for pulmonary edema. Why am I using the daily weight as my evaluation? It just doesn't make sense. Okay. Then you'll get into their previous medical history, their risk factors. Do they have a familial history? Have they been exposed to anything? Just walk your way through your navigators, and it will help you out immensely. Pain is going to be big for us when we talk about CAD, ACS, MI. So again, we just review. Make sure that you are following up with the onset, provocation, quality, region/radiation, severity, and time. You guys, time is going to be really important if you're talking neuro for stroke or if you're talking cardiac for MI. And severity is a big deal. Okay? When we are doing our everyday pain assessment and we think about, okay, I can't really give this client anything for pain. It's, they're complaining of pain constantly. It's always a 10 out of 10. What you need to do is think about your non-pharmacological pain management. Have I been doing this long enough to understand that most patients probably don't want to hear that? Their experience with pain is what they say it is, all the good stuff that we teach you guys in nursing school. Which, if they have pain medication available, I'm certainly going to look into giving it to them to help out. But we have to make sure that we're offering or at least documenting on these alternative therapies, making sure that we're helping them to find other resources to kind of help with their pain control. So make sure you're looking at all that, make sure you're documenting on it as well. So we talked about relevant history, we talked about family history, social history. Hey, do you exercise or do you sit home and watch anime all day? Are you able to participate in your ADLs? What do you know about your diet? Are you eating healthy at home? Do you not have access to food? Do you have barriers? What are those socioeconomical barriers? What kind of cultural barriers or support systems do you have? What medications are you on? What allergies do you have? Okay, we're going to then move on to their general appearance. Check for capillary refill, their color, temperature, and moisture. Color, it's usually in cardio, it's red, white, or blue. We want somewhere in between those colors. So red is usually erythema, blue is cyanosis, white is pallor. Are they sweating or are they diaphoretic because they're having chest pain? What are their vital signs? Do they have changes in orthostatic blood pressures? Do they have normal pulses? You have +2, +1, and then if they do have an absent pedal pulse, or you can't palpate it at least, are you doing the correct things and grabbing a Doppler, or are you just letting it go? You can look and listen and feel for pulse deficits, and of course, take blood pressures initially, especially if you have significant changes. Take blood pressures in both arms, and then do your orthos. Normally, what we probably see and what you're used to is if it's a new diagnosis, you'll get a set of orthos, or if they're getting ready to get discharged, you'll probably get a set of orthos. Maybe if you have an acute change in condition and the client can stand or sit, you can also grab a set. So this we've talked about already again. So we're bringing it back up. That must be important, right? Problems with our urinary system or bowel elimination. We tend not to do Foley's a lot anymore, but it's still important that if you have a history of heart failure or chronic kidney disease, that you're doing accurate I's and O's, right? We need to know that whatever we're putting in is coming out. And that's that whole process of them talking to us about their weight gain. We'll tell you the rules for weight gain once we get to heart failure. I's and O's are indicators of increased perfusion, right? Oxygen, we don't think about it a whole lot, but oxygen is a vasoconstrictor. So we will have clients come in and their blood pressure is 200 over 100 and SpO2 is 80, and then we put them on oxygen, and that oxygen helps their blood pressure stay elevated. So we got to do the things that we would compensate for the things that our body would normally do for itself. But again, I's and O's are the number one missed concept on a cardiac exam. And the kidneys and the heart are so linked together that it's impossible for me to understand, because every semester I sit here and say that I's and O's are the number one missed concept exam on my test. So make sure you're looking at that information. Make sure you're evaluating your medications. All right? And over here we see the diagram here of the link between heart failure and chronic kidney disease. And again, it's a big circle. So you have medications that affect both. You have chronic inflammation. You have activation of the renin-angiotensin-aldosterone system. And of course, you have changes in your cardiac output or your hemodynamic changes. You have certain risk factors and then certain disease processes that tend to make one or the other worse. So make sure you are asking yourself, is my client making urine? Okay, so we're going to look, feel, and listen. So we're looking for symmetrical expansion of the chest wall, no other abnormal motions, no flail chest, things like that, no absent lung sounds on one side. We're watching the rise and fall of the chest. Counting a respiratory rate, a real respiratory rate, never trust the machine. That we're doing our assessments, there's no thrills, no weak and thready pulses, no irregularity, that you're listening to the heart sound at the PMI, you're getting your apical heart rates, and then we hear normal S1 and S2 without murmur. Even if they have a murmur, it's probably not a big deal initially, as long as we control it. But we want to make sure that they don't have these extra heart sounds. We talked about the S3 and S4. I don't expect any new nurse to know what S3 and S4 are. Early or late heart sounds or gallops. If you hear a different heart sound, ask for help, because until you've actually listened to it on a real client, it's not going to make a whole lot of sense. So we talked about murmurs. We said we'll talk about that with heart failure and with congenital heart disease. And it's just because they have this turbulent blood flow. There's been a structural change to the valves, whatever it may be. And this is kind of what we're talking about when we talk about these extra heart sounds. You see S4 actually becomes before S1, and then S3 comes after S2 and before S4, and then it starts that whole pattern over again. So again, if you're unsure, ask for help. A pericardial friction rub, that's we think equate it to you rubbing your fingers between your hair. Give it a second, let you all do that. So when you hear that sound, that rubbing sound, that's what a pericardial friction rub sounds like. If you hear that, obviously that means they've got an infection in their heart and we need to do something. We've talked about palpating pulses, checking for weak and thready or absent peripheral pulses, because you can have arterial occlusions, you can have different arrhythmias, changes in your blood pressure. One rule I will say, I was actually out and about. I was doing rehab after I ruptured my Achilles tendon, and we had a client go down in the rehab center, and nobody knew what to do. They couldn't figure out what was going on, and I had to go over, and kind of walk them through what to do until EMS got there. And they were all worried that she didn't have this blood pressure. And I'm like, well, what's her pulse? And they were able to feel a pulse. I said, okay, so here's the general rule. If you have a pulse, you have a blood pressure. You may not be able to pick up that blood pressure, so we may want to consider something more invasive. But if they have a pulse, they have a blood pressure. The other thing that I want to make sure is that if you're assessing your normal pulses, so your radial, you can do the brachial if we have IVs or something running. We can always switch to a different site. Just never put the blood pressure cuff above where that IV is. What I want you to do is when you're checking your radial pulses, you check them both at the same time. You can do that same with your brachial pulses. They're harder to palpate, but that's the one where we get the blood pressures. Popliteal, if they have BKA, AKA, whatever it may be, we want to assess what's there for it. So BKA, you can go ahead and still do the popliteal, but if it's an AKA, you're going to do the femoral, because you still want to make sure that they're perfusing that portion of their leg. And then your pedal pulses. Make sure that you're assessing both. All right, and it's your dorsalis pedis and your posterior tibia. Again, just like you would do with your radial arteries, you want to palpate them at the same time. Because if you have changes, it means you could potentially have complications. Say if you went out for a cardiac cath and you came back and now I'm no longer able to feel your pedal pulses, that's an issue. The carotid, generally you're going to do that only if it's a emergency situation, so you can palpate the carotid, palpate the femoral. Just please, please, this whole time I've been saying, oh, palpate these pulses at the same time. Do not palpate your carotid artery pulses at the same time. That will cut off circulation to the brain. So again, this is just a different diagram or image of places to palpate on a client. So radial, brachial, femoral, popliteal, dorsalis pedis, posterior tibia, and then of course how you're going to document it. These numbers can change. I've seen it go all the way up to 4. It depends on the institution and depends on the charting system. But generally, this is good enough for entry-level nurses. We're going to look at the extremities. No rashes, no swelling, no color changes. Think yellow for jaundice. In the lower extremities, you're going to see color changes depending on PAD, PVD. You could have dark discolorations. You could have erythema. You could have pallor. Worse, you could have cyanosis. We want to examine for venous stasis, and that can manifest as either decreased, diminished pulses, edema, or as DVT. So venous stasis is part of that Vickhaus triad. You want to assess for arterial insufficiencies in the legs. So we're going to ask them, hey, when you get up and walk, do you experiencing any abnormal pain? And that's that claudication that we talked about earlier. You should see normal hair distribution, no changes in pigment around the ankles, no clubbing in the fingernails, no decreased capillary refills. When you do palpation, that their hands and their feet are warm and pink. It depends on the client. The geriatric clients can generally tend to feel colder because they don't have as much subcutaneous fat. And then obviously making sure that there is no pitting or non-pitting edema. So if you do have an absent pulse in the extremity. Remember, this is peripheral arterial. And generally speaking, we're going to say it's probably an acute arterial occlusion. So you're going to look for, again, those changes. So the first thing you see is the red, white, or blue, and obviously they are very red. Check the pulses with a Doppler if you can't feel. And if you are using a handheld Doppler and it's not picking up anything, you want to make sure that you're letting somebody know and getting them scheduled for a duplex Doppler as soon as possible. All right, so when we're looking at those things, just sum it up, we're looking at circulation, motor control, and sensation. We want to look and make sure that there's no JVD or pulsations. You generally have to be sitting them up at least at a 45-degree angle to see any kind of JVD. You want to auscultate for no carotid bruits. So you put it in your stethoscope on one side. And honestly, nurses don't do that. That's more of an NP/MD type of thing to do. But, if they're having frequent changes in LOCs or issues with anoxia, you can listen to see if you hear anything. So no bruits, no thrills, no murmurs, looking for our pulses to be normal with each other and for the client. And that is the end. Okay. So we've talked a lot. What I want to say for especially my folks is that if you are kind of reviewing this and you're still a little lost, it's okay. We know as faculty that most of these concepts in cardiovascular are new, or at least new to you. And what you're going to see is that when now we talk about CAD, ACS, when we talk about heart failure or dysrhythmias, all of those same concepts are going to be ingrained into those lectures. So we'll give you a couple of examples here. All right. Most of these you can find out there online. I am a firm believer, for all my folks, I'm a firm believer in AI, where you guys can upload your PowerPoints and have it create either a summary or have it create practice questions. There's only so many ways I can ask you about the cardiovascular system. And generally, in the question, we're going to give you enough information to answer it. So here we have this exemplar, and I say a nurse enters a client's room and finds him unresponsive. So now you have to think, okay, I've got an unresponsive client. Oh, I've already notified the rapid response team. Which of the following actions should you take? And then there's that key word, first. All right. So, do you want to attach defibrillator pads to the client? Do you want to check for carotid pulse? Do you want to begin chest compressions? Or do you want to deliver 2 breaths? What I would say for this question is that all of those things are plausible. And to be a good distractor, it should be plausible, right? If he's unresponsive because of VFib VTach, I probably need to put defibrillator pads. But I think we're well enough along the way for you guys, for my students here in the 4th semester, that you guys probably know that that's not the first thing that you should do. So, check a carotid pulse, begin chest compressions, or deliver 2 breaths. Notice that each part of that is part of our BLS. So what's the first thing that I need to do? I need to feel for a pulse. So there is no worse feeling in the world than going into a room, my students, you know this story, and going, oh, okay, does the client have a pulse? And the nurses tell you no, and then you start chest compression, and the patient opens their eyes, looks at you, and yells. So, check for a pulse first. We don't just go perform CPR or rescue breaths on a client without having further information. And that further information is to check for a pulse. Now, this lecture was not about aortic stenosis, but that's okay, and I'll show you why. So I have a client with a history of aortic stenosis is admitted to the cardiac progressive care unit. What nursing intervention should the nurse include in the plan of care? All right. I said from the very beginning, the very slide number 2, we talked about blood flow. So if you remember where the aortic valve is, then you can remember what you should do if you have something that is impeding blood flow. Where is it going to back up to? All right, so I can listen to lung sounds. I can give nitroglycerin for chest pain. What I notice is a lot of my students, because I tell them, hey, with aortic stenosis, you can have chest pain. But notice up here, it does not say anything about chest pain in the question. So why would I give nitroglycerin if I'm not telling you that they're having chest pain? It's because we like to make those assumptions, the what ifs. What about this? What about that? Actually, nitroglycerin would be probably contraindicated for aortic stenosis because it decreases preload and afterload. Do we want to position that client in a supine position? Okay, I don't know why that we would want to do that for aortic stenosis. Kind of a throwaway answer, but what my students will tend to see is they will read this word and they will think, oh, well, I want to raise the head of the bed, and they won't finish the rest of the sentence. So that really leaves me down to 2, and there are both very plausible. Do I want to listen to breath sounds, or do I want to do something? This administration of high flow oxygen, is an airway breathing circulation answer. The problem with that, because you guys know I'm a big fan of ABCs, the problem with that is that this client is not experiencing an acute change in condition. And to use airway breathing circulation, I have to have an acute change in condition. So if I get it down between those two, and I know there's only one correct answer, because if I have an impediment, blood will back up into the lungs. I need to make sure that I'm assessing for that potential complication. There is no indication that this client needs oxygen yet. Okay. A nurse is caring for a client with a central venous pressure of 16. Now, we talked about the central venous pressure briefly, and I gave you some numbers. I said high or low. Low means dry, high means wet. Which medication should the nurse expect to administer? So if I'm wet, what do I expect to administer? Beta blocker, calcium channel blocker, so propranolol, nifedipine, normal saline, or furosemide. So I think right away, if we know what this means, we are going to be able to see what to do if I can get my computer to move forward. Yeah. So they're wet. You guys know what to do for a client who is wet. I gave you an assessment that was abnormal. And basically, you're going to take this question and you reword it. What should the nurse know, or what should the nurse do about a high CVP? I don't know that propranolol or nifedipine are going to do anything. This is a throwaway answer. You know, sometimes we're nice and we give you those throwaway answers. So that only leaves you with one option. This is typically what we would expect to see on a client who had either in an ICU or a step down. So when you're looking at this, I see PQRST on the monitor, I see that their heart rate is 67. I see that their blood pressure is 95 or over 42. I see that their SpO2 is 59 and their respiratory rate is 28. So I could put this on a test and say, okay, which assessment requires immediate intervention? And for some reason, students will like, oh my gosh, it's this one. Their blood pressure is low, and what's their MAP? And let's calculate their MAP. And then we totally overlook this. That just makes no sense, right? It's like, well, I thought that the SpO2 was low because of the blood pressure. Yeah, but the SpO2 is critically low. So if I'm going to do something first, what is most concerning is that their SpO2 is 59. And it's usually these easy, kind of straightforward questions, or what I would think was straightforward, are the questions that students will miss. You know, why aren't you giving oxygen to the client whose SpO2 is 59? Well, it's a cardiac test, Mr. Shockley. Well, what are my 3 favorite words? Perfusion, perfusion, perfusion. Again, so this is just something that nobody is trying to trick you guys. NCLEX will not try to trick you. They're going to give you a situation. They're going to expect you to make a clinical judgment decision on that information, and then you're going to move forward. And if you can do one thing and walk away, what would it be? I can start fluids for this client for the blood pressure. That is not going to fix that SpO2 of 59. All right. If you have any questions, feel free to reach out to me. I'd be more than happy to answer any questions that you have or clear up anything that I did a poor job on explaining. Again, I think it's important. I want you guys to remember this is for basic nurses. Really, even though this presentation was an hour plus long, you should fit all the testable information. It should fit on one sheet of paper. And I know you guys don't like hearing that. But what happens is my students tend to overwhelm themselves with notes. And then I will, hey, let's go through your notes. Let's look at what you do. And then for low cardiac output, they have like 10 pages of notes. I can't remember 10 pages of notes when I get to the test. But what I can remember to do is that I need to do something to correct the underlying problem. What's the problem of my situation? And that's where you guys should be at, making sure that you keep things as simple as possible. All right, we'll have another one for your cardiac diagnostic and laboratory exam, so your diagnostic tests. We'll get that up and posted as soon as possible.